All right, let's talk about dermatitis herpetiformis. Now, the name makes you think it's just a skin thing, right? But what if I told you it's actually celiac disease showing up on your skin? It's a wild connection that starts deep inside the gut. So let's get into it.
Here's what we're going to cover. First, we'll explore that weird gut-skin connection. Then, we'll dive into the autoimmune mess that causes it. We'll look at what you'll actually see, both on the skin and, super important for you, in the mouth. After that, we'll talk about how to get a definitive diagnosis, how to tell it apart from its lookalikes, and finally, what the treatment and long-term outlook are.
Okay, so let's start with this central mystery. How can what's happening in your digestive system cause a crazy itchy rash on your skin? It sounds pretty out there, but trust me, this connection is the key to understanding absolutely everything about this disease.
I mean, really think about that. How can eating something as common as bread or pasta lead to an intensely itchy rash? This isn't your typical food allergy, like getting hives. No, this is something way deeper, a complex autoimmune mix-up where the skin becomes the battlefield, and it all starts with one very common ingredient.
And there it is, the big reveal. Dermatitis herpetiformis, or DH, isn't just linked to celiac disease, it is celiac disease of the skin. It's the skin's way of screaming that the body is having a bad reaction to gluten. So the same internal process that wrecks the gut lining in someone with celiac is what's causing this miserable, blistering rash on the outside.
So how exactly does this happen? Let's follow the breadcrumbs, literally, from a piece of toast all the way to a blister on the skin. This is the chain reaction that you, as future clinicians, really need to wrap your heads around.
Okay, let's walk through it. It all starts when a person who is genetically susceptible eats gluten. Their immune system freaks out and starts making these IgA autoantibodies. Now here's the crazy part, step 3. These antibodies don't just stay in the gut. They get into the bloodstream and end up getting deposited in the skin, specifically at the very tips of the dermal papillae. Think of them as setting up camp right where the outer skin meets the inner skin. This deposition acts like a flare, calling in the troops. That's step 4. And finally, step 5, all that inflammation from the neutrophils and eosinophils causes the layers of the skin to pull apart, and bam, you get a blister.
And when we say genetic link, we are not kidding. A whopping 90% of patients with DH and celiac disease have a specific genetic marker called the HLA-DQ2 haplotype. 90%. That's a huge number. It tells us this isn't random. There's a powerful genetic predisposition at play here. All right, so we've covered the why. Now let's get practical and talk about the what. What does this actually look like when a patient walks into your clinic? We'll go over the classic skin signs and, most importantly for you, what you might see in the mouth. The skin signs are pretty classic. It usually hits young and middle-aged adults and comes in waves, flaring up and then calming down. The number one symptom is the itch. It's an itch so bad that patients often scratch the blisters right off before they can even form. And the location is a dead giveaway. It's symmetrical. You'll see it on both elbows or both knees, the shoulders, and the lower back or buttocks. Don't forget to check the scalp and face too.
Okay, now for the part that's directly in your wheelhouse. Oral lesions are not common in DH. You're not going to see this every day. But uncommon doesn't mean impossible, and as a dental professional, you need to have this on your radar.
So if you do see it in the mouth, what's it going to look like? Well, it can pop up anywhere. Gums, cheeks, you name it. It starts as little blisters, but because the mouth is such a high-traffic area, they break almost immediately. So what you'll probably see are just some non-specific ulcers. They'll have that yellowish white base and a red halo around them. At first glance, you might just think canker sore. But if the patient has a suspicious rash elsewhere, a light bulb should go off in your head.
Seeing the signs is one thing, but to be 100% sure, you have to look deeper. We're talking microscopic. This is how we separate DH from all the other things out there that can cause blisters and sores.
So, a regular biopsy gives us some really strong clues. Under the microscope, you'll see that split between the skin layers. That's your blister. But the real telltale sign is these little collections of inflammatory cells, these tiny abscesses full of neutrophils, right at the tips of the dermal papillae. It perfectly matches the story we told about how this all gets started.
But while the regular biopsy is good, it's not the final word. The absolute, without a doubt, gold standard test is something called direct immunofluorescence, or DIF. This is the test that gives you the smoking gun.
And this right here is why. This is the money slide. The DIF test actually lights up those IgA autoantibodies we were talking about. And when you see a granular, like a speckled or dot-like pattern of IgA deposits right at the tips of those papillae, That's it. Game over. That is the pathognomic sign. It's specific for DH. If you remember one thing for your exams, make it this.
Of course, in the real world, things are messy. A few other conditions can look like DHA, so you've got to be able to tell them apart to make sure your patient gets the right treatment. Let's talk about the main imposter.
The number one mimic is a condition called linear IgA-bullous disease, or LAD. They both involve IgA, but they are totally different beasts. First off, LAD has zero connection to celiac disease. And remember that granular IgA pattern? In LAD, the IgA deposits form a solid, clean line all along the base of the epidermis. Granular versus linear. It's a huge difference, and it changes everything, especially treatment. A gluten-free diet will do absolutely nothing for a patient with LAD.
So that brings us to treatment. Once you have that solid diagnosis, the game plan has two parts. You've got to control the disease for the long haul, and you've got to give the patient some immediate relief from their symptoms.
Think of it like a 1-2 punch. The first punch, goal 1, is managing the underlying disease. The only way to do that is a strict, lifelong, no-cheating, gluten-free diet. That's what stops the autoimmune process at its source. But that takes time to work, so you need a second punch, goal 2, which is controlling the symptoms right now. For that agonizing itch, we use drugs like dapsone to put out the fire while the diet starts to work its magic.
So, what can patients expect long-term? Look, this is a lifelong condition. There's no magic cure. But the good news is, it's very manageable. With a strict gluten-free diet and medications as needed, patients can often get the disease under control and enjoy long periods of remission, feeling perfectly normal.
Okay, let's wrap this up with the high-yield points you need to take away. 1. DH is not a skin disease. It's a gut disease that shows up on the skin. It's a sign of systemic autoimmune disease. 2. Keep an eye out for those nonspecific ulcers in the mouth. They're rare, but you might be the one to spot them. 3. Knowing about this link is huge. You could be the one to make a life-changing referral. And 4. For your boards and for life, granular IgA deposits. That's the key.
Hey, if you found this helpful and you want more deep dives into oral pathology like this, come find us on YouTube. Just search for Master Oral Path. We've got tons of content to help you ace your classes and boards.
And I'll leave you with this question to chew on. DHS is a perfect example of the mouth being a window to the rest of the body. What other huge systemic diseases are out there just waiting to be discovered, hiding in plain sight in the oral cavity? Thanks for tuning in.